Good afternoon. I'm Sherilyn Francis with the National Center for Primary Care, and we welcome you to part 2 of our tobacco cessation series. We invite you to connect with us via social media at PriCareMatters using hashtag eCigarettes. Additionally, for resources and for this webinar presentation, we ask you to go to www.primarycarematters.org. Today's webinar is brought to you by the National Center for Primary Care, and we are located at the Morehouse School of Medicine. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in serving underserved areas. The core principles of the NCPC are access, effectiveness, and equity. The objectives for today's webinar are to analyze the similarities between big tobacco and the e-cigarette industry, to compare big tobacco and e-cigarette advertising, identify the benefits to big tobacco in the e-cigarette market, to analyze e-cigarette national trends and best practices associated with tobacco cessation, and to critique the research regarding e-cigarettes as a gateway drug. I now present to you today's webinar entitled Big Tobacco's Interest in eCigs, presented by Dr. Robert Jackler and Dr. Zachary Kahn. In compliance with ACCME guidelines, neither presenter has any financial or other relationships with manufacturers of any commercial service discussed in this educational activity. And now Dr. Jackler. Dr. Jackler, can you begin by describing the work of the Stanford Research into the impact of tobacco advertising?
Thank you very much. For those of you on the East Coast, good afternoon. For those of you with me here on the left coast, good morning. First of all, I have no conflicts of interest with any of the tobacco organizations, not surprisingly. So what is the work that we do? For close to the last 15 years, I have created a research group here at Stanford University that looks at the marketing and advertising behavior of the tobacco industry. Now, one of the things we began with is to create a very large repository of tobacco advertising material, because in fact, high-resolution images have not been provided previously in large numbers. We have a relationship with the Smithsonian Institution and have donated some 50,000 original tobacco ads to the National Museum of American History. So in terms of what we present on the web, you can see across the top of the slide in front of you, there's a large collection of cigarettes, e-cigarettes, and it's compartmentalized with chewing tobacco, hookah, pipes, and cigars, with many, many advertising images therein. We're also, interestingly enough, looking at legalized marijuana and also at medicinal as well as fully recreational marijuana. So, of course, being at a major university, we do research. Our research is largely regulatory research, seeking to inform legislators and regulators and the legal process about the advertising behavior of the industry. Now, we're pleased. Part of our role is to support the work of other scholars and advocates, such as many of the folks on this line. We're approaching 500,000 unique users from literally every country in the world that uses our database. And we work hard, actually, not to be uniquely American. We have a large number of images from Russia, from many other countries, Asia, for example. Now, with regard to electronic cigarettes, a few comments about e-cigarettes and then comments relating to how the major tobacco companies have taken it over, really, in a way, or are working to do so. So one great concern that many of us have is the type of flavors that appeal to young people. Most of us would be perfectly happy if a 2-pack-a-day Marlboro smoker transitioned entirely to vapor products, and we'll talk more about that later. But these types of flavors are differential appeal to youth. While there may be an occasional adult who likes the idea of a gummy bear flavored e-cigarette, they certainly are more prevalent amongst young people than they would be mature adults. I want to call out San Francisco, who just this past week, in fact validated it yesterday literally, that they're banning flavors. And when we talk about regulation, in America it's very difficult to regulate advertising because of the First Amendment. But local, state, and national agencies can limit products, and this is what we've seen at San Francisco. Now, there's a long history of targeting young people in the world of nicotine. Why? Because largely nicotine addiction is an adolescent phenomenon. One begins to smoke as a teenager, wanting to do a behavior that makes you feel older than you are, something forbidden by adults, but then you get caught on the nicotine addiction and become often a lifelong consumer of tobacco products. Now, the e-cigarette companies, and this one is now owned by Major Blue, claim that they are not advertising targeting young people, but they clearly do. You see them all over social media. You see motifs that are clearly things that appeal to people in the teenage years. Now, this is brand new data that just came out from the CDC looking at the youth, in this case high school students, current use of tobacco products. And the overall good news that only about 1 in 5, or 20%, of teenagers in America currently, that is to say high school age teenagers, use any tobacco product. And in fact, classic cigarettes are stepping down year after year. You can see only 8% are current users. E-cigarettes had been going up extremely rapidly, as you can see, but this year they stepped down to 11.3%, suggesting that some of the novelty in electronic cigarettes, the faddishness in teenagers, is going down. Now, the original market in e-cigarettes were many, many hundreds, close to 1,000 entrepreneurial small startups. Anyone could write to a Chinese company, have their name embossed on the front of a package, and it would all come, and they could start a website and start an e-cig company. But now the majors have come in a big way. Altria with Mark 10 particularly, R.J. Reynolds with Views, which is the leading brand, Imperial after Lorillard has bought Blue, etc. And what we're seeing is not only e-cigarettes, but a whole new family of electronic devices led by IQOS, which is a Altria brand, which is heat not burn. So as opposed to a vapor, it's a heating with an effluent coming from heated tobacco that we're going to be seeing, I'm afraid, a lot more of. IQOS is now under application in America and is already on the market in many countries. Now, what's happening to the independents is they're going out of business. So Enjoy was a major independent, and the big folks pushed them out of the convenience stores and the gas stations. They took over the shelves, and Enjoy went bankrupt. Now, mind you, this is about major stores, but there are a lot of vape shops that use the advanced vaporizers into which you pour liquid. That market remains rather independent in comparison with the major tobacco industry. Now, how big is it? If you look at the Nielsen data in 2016, over 80% of the U.S. e-cigarette market in convenience stores and those kinds of outlets are now dominated by major tobacco companies. You may say, why are they going into it? Well, there are two schools of thought, and the truth is probably halfway between. Now, if you market Marlboro cigarettes, the leading combustible cigarette in America, you come out with Mark 10. I suspect they hope that their Marlboro smokers will try it, find it wanting, not satisfying their addiction or flavor, and then return to their combustible cigarettes. Why? Because the money is in traditional combustible cigarettes. E-cigarettes for these folks are largely loss leaders. The second reason that they're interested in it is because it may be the future, and in fact it may be their future business, and they have to find a way to make it profitable. And the truth is probably somewhere in between. I think the industry would like to see people try them and no longer use them, or dual use them. Use e-cigarettes to keep their nicotine levels high when they're in school, when they're at their desk at work, and in places forbidden from smoking combustible cigarettes. Now, if we look at the major companies and the way they advertise their e-cigarettes, we can see signs that they're co-marketing their combustible cigarette products. So you can see here the similarity, the piano player in a relaxed time, doing a fun thing, the woman on him almost draped as though she was an appendage of him, and you can see the smoke emanating. Now let me make a point. If you look at the tip end of this gentleman's cigarette, remember, e-cigarettes don't emanate smoke from the lit end. They do it only from the mouth end. So in fact, this image is very much of a combustible cigarette as opposed to an e-cigarette. And so we have to be concerned that when the major tobacco companies market their e-cigarettes, they're really surreptitiously marketing their tobacco products. Now, just a few comments on tobacco advertising regulation. There are many regulations about the purity of tobacco products, how they're manufactured, but there has been increasing regulation of classic cigarettes, but very little regulation beyond that. Now, if we look back to the late 1920s, over 80 years ago, they had pictures like this. If you smoke a Lucky, you won't get fat. So the government came down and said you can't do that. And so what happens? The typical thing is the industry morphs and escapes from the intent of regulators. How do you think Miss Virginia became known as Miss Virginia Slims? To tell women that if they smoke, they won't gain weight, and God forbid if they're a smoker, they quit, they'll balloon. So most of the women-targeted brands around the world today are slim or super slims, showing anorexic models as we see here. Overt health claims saying more doctors smoke Camels. Note that the M and the D are in red. And that was outlawed in 1955, 62 years ago, by an act of the Federal Trade Commission. In 1953, they said you couldn't use celebrities like John Wayne or sports stars like Willie Mays. Now, I'm going to make a point. This only applies to classic cigarettes. And in fact, e-cigarettes have done all of these things routinely over the last decade. In 1965, warning labels came in, which we know the warning labels today have very little effect in their current version. Around the world, graphic pack warnings have come in, taking over with vivid images much of the front of packs and of advertising. In 1971, Congress banned radio and TV ads. I remember the Flintstones, sponsored by Winston, when I was a boy. Today, e-cigarettes are back on the Emmy Awards, they're back on the Super Bowl TV programs hawking their wares. Now, 19 years ago, there was a settlement agreement with the major tobacco companies, which got rid of Joe Camel in cartoons, bulletin boards, movie product placements, and the like. Now, in 2009, Congress came in and said that you can no longer sell flavored cigarettes except for flavored with menthol as a characterizing flavor. So this is very different than what e-cigarettes are today, as we'll talk about. And so what happens? After 2009, saw a proliferation in 7-Eleven and all these stores of mini cigars getting smaller and smaller and more cigarette-like in vivid flavors, as you can see here, taking up much more shelf space, 2 for $89 or $1.19. And so these have become extremely popular amongst young smokers. So the FDA in May 2016 came out with a series of deeming regulations for electronic cigarettes. They said that e-cigarettes were tobacco products and part of the FDA's purview according to the 2009 law. So it means no sales under age 21, no overt health claims, warning labels for nicotine, no free samples, and you can't tell them that they're good for quitting unless the science shows it. But there are glaring omissions from these deeming regulations, many of which still have not been invoked to today. And that is, there's no limits on flavors, on radio or TV ads, on sponsorship or celebrity endorsements, for example. So with that, I'll pass it over to my friend Zach.
Dr. Khan, should health professionals counter the harm reduction argument?
That is an excellent question, and I want to thank Dr. Jackler for that excellent overview of e-cigarette ads and how similar they are to what we've seen before. So should we be countering the harm reduction argument? I'll get to this in more detail, but the short answer is, in the past we probably should have, but at present we need to be cautious. So what is harm reduction? This, in general, involves strategies to minimize the dangers associated with a risky behavior, any risky behavior, as opposed to trying to minimize the occurrence or incidence of that behavior. Of course, both often make sense, and there's no inconsistency in both recommending against the behavior and then advocating for taking precaution should one engage in it. But from a practical standpoint, abstinence-oriented and harm reduction approaches can conflict. There's limited resources among public health groups, so if you're emphasizing one message, you might not be emphasizing the other. And if you lower the risk of something, it might make that activity seem more appealing because it's less risky. And so this harm reduction framework, where you can either seek to reduce the occurrence of an activity or the dangers associated with it, is applicable to all sorts of behaviors, including the ones listed here, but you could probably think of more yourself if you just took 1 minute. For harm reduction and tobacco control, there's a long history of it, but first the rationale. In general, nicotine is the reason why most people smoke. It contains the psychoactive ingredient. That's what most smokers are really after for the most part. And the tar, a byproduct of getting that nicotine, is where most of the harm comes in. And that is sort of the general rationale. So it seems logical that if you could somehow just reduce or eliminate that tar while keeping the nicotine, that you would have significantly reduced harm for people who are still using nicotine. There was a lot of optimism in the 50s and 60s that that would be possible. And there was involvement of a lot of health groups, including Surgeon General Luther Terry, who authored the famous Surgeon General's report in 1964. And he saw the development of better filters and more selective filters as a promising avenue for further development. But he wasn't the only one. The FTC regulated tar and nicotine disclosures that were meant to signify gradations in harm. And the NCI actually conducted a less hazardous cigarette working group with the intent of attempting to reduce or spur along innovation that might lead to less hazardous cigarettes. And Dr. Jackler has shown a ton of these advertisements, but this was sort of what harm reduction looked like in practice. You saw light and low tar cigarettes either advertising explicitly or implicitly that they would be less dangerous. Of course, this didn't go well, and in fact it went very poorly. It's known as a disaster. Light and low tar cigarettes did not substantially lower disease risk, and a large proportion of people who might have quit instead continued to smoke low tar and light. And so in retrospect, I think it's safe to say we would have been better off shunning harm reduction efforts that revolved around less hazardous cigarettes during this period. In a sense, it was these optimistic harm reduction efforts really backfired from the 50s through the 80s and 90s. So there was a lot of fallout as a result of this failure. One was suspicion of harm reduction approaches in general. They didn't go well in the past, and so any time that they've come up since, there's been the first thing that comes to mind is lights and low tars, which were again disastrous. Second, they've added to the distrust of the tobacco industry, and I think Dr. Jackler showed you a lot of the deceptive and underhanded conduct of the industry even today. But there was all manner of dishonest behavior from the 40s and 50s onward that led to the tobacco industry becoming pariahs. To name just a few, they lied about the known dangers of smoking. They lied about their efforts to create less hazardous products. They lied about the addictiveness of smoking, the importance of nicotine. They designed filters that would fool FTC smoking machines, and on and on. And so even pro-harm reduction advocates, people who are generally supportive of the notion that you can get consumers to use less harmful types of nicotine, remain quite suspicious about the ability or motivation of the tobacco industry to develop reduced hazard products. So what went wrong? Why were tobacco companies unable to produce reduced hazard products? Well, first off, they weren't really trying. all that hard. In some cases, not at all. They were creating products that might seem less hazardous, but were essentially no different. And second of all, the approach that they were generally taking was a top-down approach. Taking the harm out of smoke is essentially impossible. Now, there might be reasons why you would regulate the ingredients and manufacture of combustibles, but you will never be able to create one that is not extremely hazardous. But that was essentially what they were trying to do. Then what you would need to do is something closer to turning NRT or isolated nicotine into something that resembles a cigarette. That's essentially what e-cigarettes attempt to do. But this was difficult for several other reasons. There were technological barriers, the aerosolization and battery technology. The politics. Tobacco farmers have long been close allies of the manufacturers and play into their political strategy. And they were not too keen on the notion of non-tobacco nicotine products. Litigation, claiming that smoking was not addictive and nicotine is incidental, was really important to the tobacco industry litigation strategy for a lot of the 90s when this sort of research might have taken place. And it would look sort of funny to then introduce products that are essentially nicotine only. And then regulation, there were stricter regulations for products that did not contain tobacco than there were for products that include tobacco. Lastly, business. As Dr. Jackler got into, these products might disrupt the marketplace, but the status quo was extremely profitable. So that disruption could come at a huge cost in terms of reduced profit. So what's happened since then? E-cigarettes emerged, and they emerged from outside of the tobacco industry. They were invented outside of the U.S. as well, and perhaps due to some of those obstacles that I mentioned earlier is why help explain why they were invented outside the industry and outside the country. What might have changed for each of those obstacles between the 90s and today? Well, the technological barriers are greatly reduced. Battery technology has advanced a lot, for example. The politics are slightly different as globalization frayed the alliance between manufacturers and farmers. Litigation is still around, but denial of addictiveness of nicotine is no longer core to the legal defense strategy of the industry. Regulations have changed somewhat. We now have the Family Smoking Prevention and Tobacco Control Act, and which put the FDA in charge of this and created a more straightforward pathway for non-tobacco nicotine products, although tobacco cigarettes are still more or less grandfathered onto the market. And from a business perspective, a competitive marketplace has already emerged, and so it would be difficult to try to ignore or stop e-cigarette development, even if they wanted to.
Dr. Khan, with all these changes, is it possible for us to trust big tobacco or e-cigarette manufacturers?
Well, that is another excellent question, and the answer is of course not. We can't trust the tobacco companies. We will never really be able to do anything approaching trusting these companies. However, we can't also just assume that today's products are equivalent to lights in the past, especially those products that don't actually contain tobacco. They contain nicotine derived from tobacco, which makes them a tobacco product, e-cigarettes that is. But if they're not heat not burn, and if they use isolated nicotine along the lines of the patches and gum, then they can't be assumed to be dangerous in the way that light cigarettes were. And I think the most important thing looking forward is to simply be truthful and accurate with everything we do know, including admitting the various uncertainties regarding really exactly how harmful these are, and avoiding inaccurate or misleading messages because they're doubly harmful. They misinform the public, of course, but they also can undermine the credibility of the organizations that we care about. So as much as we cannot trust the tobacco companies and need to really be vigilant about the things they might be trying to do. Dr. Jackler has really done a good job of highlighting some of those. We can't simply assume that they are going to do the exact same sort of villainy that occurred in the past. And I think an example of maybe a smarter way of going about it is what the US FDA has been doing recently on Twitter, which is a campaign, they've noticed, like maybe many of you have noticed, that e-cigarettes have been exploding all over the country and the world. And a lot of that has to do with the way that batteries are being handled. And so they have some common sense guidelines about how to handle batteries in e-cigarette products. I don't believe that they're actually recommending that people use e-cigarettes, but what they're saying here, what this says to me, is if people are going to, we're going to try and minimize the harms associated with these products. And I think that that's smart and is sort of the right approach going forward. And that's all my prepared slides, but I think there might be a Q&A for Dr. Jackler and I.
Okay, wonderful. Thank you both very much for extremely informative presentations. We are now open for Q&A. We have your questions and requested resources from the registration process. However, we are taking questions live and requested resources live. So this question is for Dr. Khan and Dr. Jackler. Why is nicotine dependence treated differently than other drug dependence, ergo THC, benzos, narcotics, etc.?
Okay. Just to encapsulate, I'm not sure that the premise that there is a difference is really there. Both of them are types of either behavioral or pharmacological addictions, or both. Food addiction may not be pharmacological, but it's certainly an addiction in a massively obese person. Certainly opiates and benzodiazepines and nicotine share chemical addiction, but each have their own specific wrinkles to them. The patient of mine with both heroin addiction and nicotine addiction said it was much easier to get off heroin than it was nicotine, which was very challenging. The tools that are used medically, both drugs and withdrawal, as well as psychologically, probably have some commonality across addictions, but I don't think you can draw a different line. I will say, and I think it's an important point, there is but one cause, the largest cause of preventable death in America, and that is tobacco addiction. It's the same thing as having 4 747s crash every day in this country in terms of death, but in fact the bigger problem is the loss of vigor as one grows older. The fact that a grandparent can't chase around their grandchild because they're short of breath or having chest pain. The fact that they have ulcers on their feet because of smoking. So it's a long-winded answer, but there isn't a clear distinction of the tools and techniques used necessarily with other forms of detrimental addiction.
Thank you for that, Dr. Jackler. I would only just add one slight point to that, which, and I apologize if this is redundant, but cigarettes are grandfathered onto the market and sold at gas stations and convenience stores everywhere. And so it's led to a situation, in part, nicotine is treated differently because it's always been treated differently. Tobacco was a cash crop in the colonies before the country even began. And so it's because cigarettes are grandfathered onto the market, there's a different approach to what novel and new products are versus if those products contain THC or any other sort of drug. Nicotine essentially has its own code in the FDA because it was not initially included, and so there's a long historical and regulatory context that has made it so. But as Dr. Jackler said, it's not really because it's less harmful or shouldn't be regulated in a more rigorous way.
Okay, we'll move on to our next question. Are there really nicotine-free e-cigs, and are there still health effects regardless of the presence of nicotine?
Sure. If I can handle that initially, if we go back to regular cigarettes, combustible cigarettes, people smoke for the nicotine, but they die from the tar and the effect of it. Nicotine itself, while it's not healthful, is and not perhaps as benign an addiction as caffeine, is not in and of itself terribly toxic. Obviously, it's a dangerous chemical, but in the doses you get, e-cigarettes that lack lack nicotine are probably not much different than the basic vehicle. Now, let me mention the vapor and the liquid that's vaporized is made of glycerin and propylene glycol. Now, breathing those substances deeply in the lungs over and over all day for years is very possibly detrimental and damaging to the lungs. Keep in mind that it takes 20, 30, or 40 years before you get emphysema or lung cancer from classic combustible cigarettes. We don't know the effect of just the core vehicle, let alone the nicotine, all the flavorants that in and of themselves may have additive toxicity. Because in fact, the flavorant chemicals that may taste like banana split or popcorn, those flavorants are safe in the gut, in the gastrointestinal tract, but inhaled into the lungs, it's a very different toxicity. And in fact, they may well be very damaging. We know that, for example, from butter popcorn industrial sites where the diacetyl compounds that give the buttery flavor cause terrible problems in the lungs of the workers. And now we're putting them in liquids that our young people are breathing in and out for many years.
Well, I think that's an excellent rundown of what the remaining harms are. And I would just reiterate that just the very heat of these products, there are some studies on looking at how carcinogenic coffee might be, and the finding so far is that coffee is not a carcinogen, but drinking very hot coffee or tea is on the radar as being something that might actually harm the throat and lead to different throat cancers. And so it's possible that simply inhaling something so hot into the lungs, regardless of what's in it, could also be problematic. And so, it's not even just the chemical constituents involved.
Yeah, if I could add to that, the small sticks, the cigalites, have a very low power and relatively little heating. But more and more, the market is being taken over by the advanced personal vaporizers with large batteries that highly heat the base glycerin and propylene glycol. And that high heat and high power produces formaldehyde and other aldehydes and ketones that are known carcinogens. So I completely agree with what's said about heating. And it may not be just the thermal effect. It may actually be production of chemicals that occur due to the heated vaporization breaking down the base chemicals into more dangerous ones.
Okay, our next question. We have several registrants and people in the social media sphere that believe that e-cigarettes are a better alternative, especially for smoking cessation. So here's the question. What is the best way to respond to people who insist that e-cigarettes are the best way to quit?
Zach, if you like, I'm happy to take that. Okay, so if you're a 2-pack-a-day Camel smoker and you transition from that entirely to a vapor product, I think it's highly likely that you're improving your long-term outlet for health. It's likely that e-cigarettes in the end, while not being safe, not necessarily being healthy for your body or lungs, are probably not as dangerous as burning leaf and combustion products. Having said that, how good are they to help people stop smoking? The literature is very checkered on that. And I say when people actually go and study it in people who say, I want to quit smoking, there's some suggestion that it's a bit better than packs and gum, partly because it recapitulates the hand-to-mouth ritual, the oral sucking tradition that one gets used to as a smoker. But there's a lot of disappointing literature that suggests that, in fact, e-cigarettes can actually inhibit desire to quit. And the reason for that is that we know that discontinuities of nicotine level in your blood helps you to quit. When you go on an airplane and you have to wait for the plane, and then you get on the plane and you wait for your baggage, it's many hours without your nicotine dose, and that makes it easier to break the chain of addiction. If you use combustible cigarettes when you can, and you use e-cigarettes at other times when you're not allowed to because of place of use rules, then you'll actually enhance the addictiveness of the nicotine, and people who use e-cigarettes together with regular cigarettes are less likely to quit.
Thank you. So we have a question for Dr. Khan. Dr. Khan, what is the current status of the new heat not burn products?
Well, that's a good question, and I think the answer is, I'll start with the U.S. Philip Morris has what might be the leading or most well-known product at this point. It's the IQOS product that Dr. Jackler mentioned during his presentation, and they've applied for 2 applications to the U.S. FDA, one for a new tobacco product to get it on the market, and another for a modified risk tobacco product to be able to market it as being less hazardous than other tobacco products. Currently, those are very long, million-page applications that the FDA is going through, and will make a determination about whether to allow them. But globally, IQOS is on the shelves in many countries, most notably Japan, where they have a relatively high market share, along with some of the other heat-not-burn products. And so, before they really come on the market here, we're going to have a much larger sense of what they've done, how they've been received, and perhaps even what some of the short and medium-term harms are in other countries. And I would keep an eye on Japan in particular.
One caution about the heat not burn is that the industry is putting them out there as having less secondhand risk, that the risk of the smoke to others around. And you have to remember that what led to the revolution in use in the workplace, in restaurants, etc. in America was not to protect smokers from their personal choice, but rather to protect those who choose not to smoke to not be exposed to the carcinogens and the irritants that exhaled smoke puts in the environment. So I think one of their goals is to create a product that can be used in restaurants and bars and etc. to overcome what has been a major triumph, actually, of helping to protect people from becoming addicted, and that is creating zones where clean air is insisted upon. So I'm quite concerned about those claims. I think there's some initial data coming out that suggests that the heat not burn are not necessarily safer. I mean, these have to do with what are the chemicals emanated when they're heating. They may have less of certain kinds of chemicals, but more of others. Again, proving that it doesn't hurt humans in chronic use is difficult because, again, even combustible cigarettes take decades before they cause lung cancer. So, if we do approve it, it's an experiment, and it's an attempt by the tobacco industry to keep selling a deadly product.
Okay, our next question is with regard to diagnostic procedures. Are you familiar with any diagnostic tools that clinicians or medical support staff can use to determine whether or not their patients are using electronic?
There are tests that can be done in the urine, cotinine. I'm not an expert at this, but cotinine and others that can determine nicotine products and whether or not someone's been smoking. I'm not quite sure the purpose of that. Obviously, one asks the person what their tobacco or e-cigarette or oral tobacco use has been. Certainly in a jail environment or something, one might do that without the person's consent, but I think normally in medicine we don't do that kind of thing unless there's consent, or if it's some legal thing about drugs and the police are doing it.
Okay, thanks. We have a question for both of you regarding secondhand smoke and e-cigs. Is there a concern of secondhand smoke, and are there any health effects if there is a concern regarding secondhand smoke from e-cigarette use?
What I would say is the secondhand vapor is just slightly different in some ways from secondhand smoke. For one, there's very little, if any, side stream smoke, which is the smoke that just comes directly off of a burning cigarette when it's not being smoked. So there are 2 types of secondhand smoke. There's a side stream smoke, and then there's exhaled smoke. With an e-cigarette, there's exhaled vapor. That's for the most part all there is. And studies at this point have shown that there's nicotine in that exhaled vapor, and bystanders can get elevated nicotine levels similar to being around smoking from being around secondhand vapor. And so certainly for subpopulations that we know are harmed by nicotine, children, pregnant women, there are definite concerns about secondhand vapor in that sense. But After that, I would say that there is a large discrepancy in the harm aside from nicotine, where we know secondhand smoke contains all kinds of carcinogenic and toxic chemicals. Secondhand vapor, aside from nicotine, I'm not aware that there's been detection of much of the other toxins in cigarettes, but perhaps Dr. Jackler would know more.
Well, let me just add to that a little bit. Most of the studies have been done with low-power, cigarette-sized devices. But, more and more, if you see people using an electronic cigarette device, it's these big tubes and hoses, the advanced personal vaporizers where you pour the liquid into it, and they give enormous clouds. In fact, the industry sponsors cloud contests with huge plumes of vapor in competition to see who can put out the bigger ones. And, I've seen a lot of people around, at least in this area, putting out enormous clouds of exhaled vapor with very little of it absorbed and most of it put out into the environment. So I think studies need to be done about this increased tendency to high power, large volume vapor devices in terms of the amount they put out. Certainly it puts a lot of nicotine if you're in a confined space. It will put secondhand nicotine, I'm sure. Also, these big devices produce, as I mentioned, formaldehyde, which is a problem, and that may well be in the environment. I think this is an emerging area that needs more study on the toxicity.
Okay, thank you. Our next question is regards to vulnerable populations. Can you both speak to targeted marketing of tobacco products in geographic areas of low socioeconomic status?
So there's no question in America there's an inverse relationship between family income and smoking, and smoking is very expensive to do it. When it's very expensive in New York City, $12, $14 for a pack of cigarettes. Now in California, $8 or $9. A disturbing amount of income from poor people goes into feeding their tobacco addiction. The industry certainly has more premium product displays, if you will, in convenience stores and smoke stores in lower income areas than they do in higher income areas. There is certainly some targeting that looks at blue collar demographics. Certainly inner city African American. There's a lot of marketing of menthol very much directed towards inner city populations. The marketing in the stores at point of sale. The number of stores with point-of-sale advertising in inner city, poorer neighborhoods is much higher. And it's stratified by many different ethnicities, Hispanic, African American, for example, and even LGBT communities. There have been some targets in that way. So I do think that it's quite prevalent. I think that targeted marketing pervades throughout tobacco marketing, many different examples of it. But certainly a lot of the profit comes from the lower earning echelons of American society.
Thank you. For the next question, we're going to start with Dr. Khan and then transition to Dr. Jackler's perspective on this. And this may be a bit repetitive, but we definitely want to be able to have a clear answer to this question. Would either panelist recommend an electronic cigarette as a cessation method from smoking?
So this is a really critical question, and I'm sure it's something a lot of people, a question a lot of people would have, and my answer will probably be a bit unsatisfactory. And I should say that, I'm speaking only for myself and not my organization when I give this answer, but I would say that I would not recommend either for or against doing so. So if you knew of someone who had switched from combustibles, which we know to be extremely toxic, to e-cigarettes, where it's much more uncertain, but most evidence suggests it's substantially less toxic, I would not discourage that sort of behavior. But I don't think we're at a stage yet, particularly with the regulatory status, where e-cigarettes are lightly or not regulated in most cases, where it would be medically appropriate to actually recommend them in a clinical setting. And so I would say that it's sort of in between at this stage. Because of all those uncertainties, I don't think it is completely appropriate to recommend their use or to recommend against their use in all cases?
I would have to say my gut is that for a heavy smoker who desires strongly to quit, and most adult smokers want to quit, but it's really difficult to do. If they're motivated and they're going to try it, and they're not just going to layer e-cigarettes on top of their traditional smoking, I will suggest they give it a try. It's probably a little better than patches and gums, although the data is fuzzy on that, and it may prove over the longer term not to be. There's a study in New Zealand that suggests, now mind you, even if it is better, if chews and patches are 5%, e-cigarettes may be 7%, so still less than 1% of people who set out trying to quit permanently succeed over the long term. On the other hand, if they want to use it as a tool and either cease combustible or stepwise replace it, and then I would advise them to take the appropriate level of nicotine in the e-cigarette so it allows them not to use the combustible. They don't yet have in the e-cigarettes the same throat hit, the same rapid rise in nicotine that a combustible cigarette. Literally hundreds of millions of dollars have gone into freebasing nicotine through manipulating pH and other things in modern cigarettes, so that there's this huge hit of nicotine right off. E-cigarettes don't yet reproduce that. So I agree that it's nuanced, but if someone wants to try to quit and that can and they're determined to cut down or entirely eliminate their regular cigarettes, I'll certainly counsel them to give it a try.
Super. Our next question kind of is associated with the last question. Are there any organizations that clinicians or medical support staff can direct patients to in order to receive patient education regarding electronic cigarette use?
There's an enormous amount of information online, and as with all web browsing, one needs to be a filter, not a sponge. Sorry for the cigarette metaphor. There are some good ones. I think both the federal government through the CDC and others. I don't know off the top of my head. I think one of the most important things is that we educate our primary care physicians, and there is we've done a e-cigarette education for clinicians, which could also be used by patients, which is available at Stanford Continuing Medical Education as a free online education seminar. I don't know whether or not, Zach, you have some other specific ideas?
No, I don't have anything to add to that. I think that was a good wrap-up of the stuff that's out there.
Okay, as we move on to our final question, noting the reduction of e-cigarette use in 2016, what should be the focus of clinicians, medical support staff, and public health professionals regarding e-cig cessation?
That's a good question. I think there are a few ways to think about this. When it comes to e-cig cessation, I think the focus really has to be on the youth population, who, particularly those who have not smoked or have not used any product. The nicotine addiction is not as harmful as cancer and heart disease, but it's quite a big deal for young teenagers and even younger to be getting hooked on nicotine at such an early age. And I do think that the potential for e-cigarettes to do that it is worrisome, and it's important for there to be a real focus on the youth population in particular when it comes to advertising and other sorts of regulations. And then this is a bit tangential to the question, but I think the larger focus should still be on tobacco itself and combustibles. And so there's a lot of dual use between e-cigarettes and smoking, and I think part of that might be muddled messaging, where people don't know that it's much, much more dangerous to be using those combusted products, and dual use is no less harmful than smoking cigarettes outright. As long as you're smoking something, your cancer risk, heart disease risk is extremely elevated. It doesn't matter if you're a dual user or whatever. And so getting off of combustibles, and I would say I'm undecided about whether heat not burn should currently be included there, but certainly smoke tobacco is really the top priority, especially outside of the youth population.
If I can add to that, I think it's really a question of what should we do in policy about the devices, how they're marketed, and how the attributes of that device. There are two populations with regard to e-cigarettes. There's the smoker who desires to quit. We want to favor that, and if we can transition people and find ways to do it, may require advances in chemistry, etc., over time. Then there are, and the very disturbing thing is the replacement smokers, the teenagers who are initiated to nicotine addiction and get caught with it when they experiment in their youthful period of experimentation. So I believe we should get rid of all the flavors. We should make the policy for cigarettes, there are no flavors but menthol, and hopefully menthol will go away. I would hope that e-cigarettes could not have flavors except for tobacco flavor, a bitter, typical tobacco flavor that the adult accommodated smoker will find normal and not undesirable. You also could imagine if you taxed nicotine. You could have two types of e-cigarette products. You could have one that's just vapor but no nicotine, and it can have all the flavors it wants because teenagers will play with it for a couple of years wanting to feel big, and nobody's going to know that what they're smoking has no nicotine, but then when they grow out of it, they won't have that lifelong addiction to the nicotine. And then a separate one with nicotine that comes in only bitter tobacco flavor. And by the way, the flavored ones without nicotine can be cheap, and the ones with nicotine and tobacco flavored are going to be expensive. So, you have your option when you're a 15-year-old of picking up a $2 e-cigarette without nicotine or a $10 e-cigarette with nicotine that tastes awful. Then you've created a market which would favor teenagers who can express their youthful wish to be rebellious and to do things adults forbid, and at the same time not have that legacy as they grow up in nicotine addiction.
Thank you. That brings us to the conclusion of our webinar. Dr. Jackler and Dr. Khan, we thank you for an extremely informative and robust dialogue regarding Big Tobacco's interest in e-cigs. Again, the webinar presentation and recording will be made available at www.primarycarematters.org. And for all the questions and resource requests that we were not able to address during today's webinar, these resources will be housed at the Primary Care Matters website. You'll notice at the lower fields of your screen, you have the downloadable webinar presentation, in addition to Fairchild and Colgrove 2004, which is a resource which was suggested by Dr. Khan. We thank you for your attendance at today's webinar. Have a wonderful afternoon.
Thank you.